I was tasked with a pretty broad topic, both lymphomas and leukemias, and the idea of targeted therapies. And I think Dr. Venugopal started to introduce the idea of a targeted therapy to you in his last talk. And I think the way we can talk about that in broad terms is two different categories. You can talk about molecularly targeted therapies, which means that we're trying to target a gene mutation or a certain abnormal pathway within a cancer cell. And a classic example of that would be something like imatinib or Gleevec, which Dr. Burns had mentioned to you earlier, for the treatment of CML. And that's something that's really revolutionized the treatment of CML. And the other idea would be targeting things around the cancer cells, so perhaps the immune system. And Dr. Venugopal introduced that idea with talking about rituximab or obinutuzumab and how we can utilize the immune system to attack our cancers. And so for the purpose of today, I wanted to focus a little bit, since we only had 20 minutes, and I'm going to focus on leukemia just because that is my specialty. And I'm going to start by, first of all, defining some of the terminology that we're often using to talk about leukemia in the clinic with you. And then to describe some of the latest developments in treatment for a disease called acute lymphoblastic leukemia. And we'll talk a little bit about what that disease is. And so the three treatments I wanted to talk a little bit about are Blinatumomab, Inotuzumab Ozogamicin, which is quite a tongue twister, and then lastly, chimeric antigen receptor T cells, which I won't spend too much time on because Dr. Stiff is going to talk about that at the end. And then how can we talk to patients and caregivers about how to have a clinical trial discussion with your doctor, and how should we be using all these new targeted therapies? And then to ask the question, what's the right treatment for me? Because there are so many different treatment options. So first, what do we mean by acute versus chronic? We talk about this in leukemias, we talk about it in lymphomas. And so an acute disease refers to the fact that it's developing from very immature cells, typically in the bone marrow, sometimes in the lymph nodes, that then replicate and grow very quickly and aggressively. And usually if we don't treat these diseases quickly, one could die within weeks to months from them. And usually the cells are not growing up or maturing into adult cells. They stay in this infant or baby stage and just replicate in this abnormal state. And then chronic refers to often what are more mature cells that unfortunately have just mutated, and they don't function normally. So they look like our normal mature cells in some ways, but they're not functioning the way they should to do the normal functions like fighting off infection, for example. And usually they progress more slowly, and that's where Dr. Venugopal was touching on the fact that we can use a watchful, waiting approach perhaps for those patients. And so then finally, to get to the disease I'm going to talk about here, it's acute lymphoblastic leukemia. So it's putting together some of those terms. So it's an aggressive cancer that develops from a specific type of immature white blood cell in the bone marrow called lymphocytes, or lymphoblasts in this case. So some of our goals with these targeted therapies are to get you into a complete remission. And what do we mean by that? So that means the absence of any clinical signs or symptoms of disease that you might be feeling. And technically in leukemia, it means less than 5% blasts in the bone marrow. And that's when we look at your bone marrow just through a microscope. And there can't be any evidence of leukemia in any other parts of your body. So sometimes in acute leukemia, we worry about it going to the central nervous system, actually. So we wouldn't want to see it there. And then we also talk with these therapies about the idea of something called minimal residual disease. And your doctor might talk to you about this. And this is a very, very low level of leukemia, or what could be lymphoma cells, that remain in your body, in particular in the bone marrow, but we can't see them just when we look through the microscope. We have certain more sophisticated techniques to look for them. And probably even those techniques are not quite sophisticated enough, and will get better over the coming years, and we'll be able to detect even lower levels of disease in your body. And so we do look at certain things like gene mutations or chromosome abnormalities that might be characteristic for your leukemia or lymphoma. And we can also look at antigens. We've talked about the idea of antigens a few times today. So those are proteins on the surface of the leukemia or the lymphoma cell that we can track by certain techniques in order to see if those cells are still specifically present in your body. And why do we care about minimal residual disease? Well, it tells us there's probably some sort of microscopic level of the disease in your body, and that can be a higher risk for relapse down the line. So our goal is to not only get you into a complete remission, but to be negative for this minimal residual disease to optimize the long-term chance of not having the disease come back. The idea of refractory disease is that the leukemia or lymphoma did not respond to the treatment at all or did not get into a complete remission. We are aiming not just for a partial remission, which sometimes we talk about in myeloma, but for a complete remission, especially in these aggressive diseases. And then finally, the idea of relapse disease means you've achieved a remission at some point, but unfortunately, the disease did come back. And then lastly, something else that we've touched on a little bit in some of the slides today is the idea of survival from our disease. And so that's the length of time from either diagnosing the disease or starting treatment until patients are still alive or when they pass away. And so we want, obviously, you guys to be living as long as possible, to be surviving these diseases. And so we want the treatments to not only get you into a remission, but to ultimately improve the survival from these diseases. And sometimes your doctor might also mention the idea of a progression-free or a disease-free survival, which is the idea of the disease staying in a remission and not getting any worse. So I think this is about the third time that you guys have seen the idea of an antibody today. And so using the idea of targeting the immune system, that's really based on the idea of using antibodies that we normally have in our body. So in myeloma, an antibody was a bit of a bad thing. It's overproduced and it accumulates. But normally it's a good thing in our immune system that is this Y-shaped protein. Did I go back? And so essentially, this Y-shaped protein will identify, bind, and neutralize harmful proteins or things. We usually call them antigens. Most commonly, it's an infection in the body. And what we're trying to do is to have your body say, let's treat your cancer cell like something bad, like an infection, and recognize it and attack it and get rid of it. And so that's essentially what immunotherapies are trying to do. We're modeling that in the laboratory. So in acute lymphoblastic leukemia, when we look at these cancer cells, they have many different antigens or proteins on the cell surface. So this is a little similar to what Dr. Mansour was talking about with the idea of HLA typing. We're looking at lots of different proteins on the surface of the cell. And so what we can do is to design antibodies to recognize those proteins and to go after those cells. Okay, so the first drug that I'm going to talk about is something called Blinatumomab, and it was FDA approved in 2014 actually. And we call this something a little confusing. It's a bispecific T-cell engaging antibody. And the way that you can think about it and why it's bi is because it essentially has two antibodies. We have one that targets CD19 on the leukemia cell. And we have one that targets CD3 on the benign T cell in your body, in your immune system. And what it's doing is it's actually activating the T cell by targeting CD3, and it's recruiting it to the malignant tumor cell, which expresses CD19. And that way, your T cell can actually kill the leukemia cell. So this trial was a phase 2 trial, which means that we learned about what the safety of the drug was, and we wanted to find out how effective it was. And so they showed that about 40% of patients who had very relapsed or refractory disease, so these were patients who had failed many prior lines of chemotherapies. They said 80% of patients had had at least one prior chemo, not for newly diagnosed leukemia, but even for relapsed or refractory disease that had failed its initial chemotherapy, so pretty sick patients. And they showed that about 40% of them were able to go on to a transplant. I forgot to include on the slide, but of these patients who achieved a complete remission, about 80% of them were negative for that minimal residual disease. So meaning we were really not seeing any evidence of the leukemia in their body. But the survival was still a little bit short at 6.1 months. And we really are aiming, obviously, for a longer survival for people. So maybe blinatumomab is a good treatment for getting people into remission. There might need to be another step after that. So some of the side effects, and this is what's so important in thinking about these new drugs and how do we choose one versus another for you as a patient. It can be a little hard for some patients to tolerate blinatumomab. There can be fever, and part of what's causing the fever is that we're activating your immune system, and so you can feel a little bit just like you do when you have the flu. It's turning on all these different immune cells and all the different immune proteins in your body, which we call cytokines, and that causes a generalized immune reaction or inflammation. So some patients can have a pretty bad shaking fever with that. Some patients also had headache, and then there was more of a traditional neutropenic fever for patients who had low white blood cell counts or neutrophil counts. Now, something that can be a little scary for patients, and even for us as the doctors, is some of these new drugs have neurologic side effects, and that's something we've seen with blinatumomab. And it happened in 50% of the patients, and we don't altogether know why. We do think that when patients have more leukemia in their bone marrow before they start these treatments, that they have higher fevers and more fevers, and they have more of these neurologic side effects. But we don't exactly understand why that happens. So it is something we have to monitor patients closely for in the hospital. So these aren't always easy treatments that we can just start as an outpatient. Most of the neurologic side effects were mild and did spontaneously resolve, and most of them happened during that first cycle when there was a lot more leukemia present. But some of the symptoms could be just very vague, like confusion or being delirious. But sometimes it was scary and it was more serious, like a stroke or a seizure. And there were on this trial some patients who needed to come off of the trial because of these side effects. So these are important things we need to be thinking about as doctors in terms of what are some of the baseline symptoms that you have, and we wouldn't want to risk making any of those things worse with this treatment. So the next treatment I was going to discuss is something called Inotuzumab Ozogamicin. We can call it IO for short. And what this drug is doing is it's actually combining your Y-shaped protein or your antibody that we would use in the immune system to identify and bind to the leukemia cell, and then it's linked to this nice long chemical here that we call calicheamycin, which is a toxin. And so the idea is that the antibody is delivering this toxin directly to the leukemia cell, and this linker here is breaking off inside of the leukemia cell and releasing the toxin within the cell. So it's a little bit more sophisticated than just giving chemotherapy throughout your whole body, or it can affect all your cells. The idea is hopefully it's mostly affecting your leukemia cells. So this was a trial that compared this new drug, inotuzumab, to standard of care chemotherapy. So we could figure out if they're equally good, if one is better than the other. These patients had not had as many treatments as the blinatumomab patients. Most of them were in their first relapse. A fair number of them were pretty young, under the age of 55, and about 40% of them had stayed in their first remission for more than 12 months, which is usually a better sign that their disease responded to that first treatment. Now, it also had side effects. So some of the more concerning side effects with inotuzumab is it can affect the liver and the gallbladder, and it could cause something called veno-occlusive disease at a higher rate than chemotherapy. And the reason we care about that is it causes a blockage in the small veins in the liver, and it can cause the patient to accumulate fluid and to have high liver function tests, especially the bilirubin. And it seemed to happen both during treatment and for patients that went on to transplant. And so that's important because obviously we want your liver function to be normal when you're undergoing something stressful like a transplant afterwards. So that might be something your doctor would talk about in terms of picking, is that a good treatment for you or not? So it's a very effective treatment for patients who have had relapsed or refractory ALL. So it demonstrated that the complete remission rate was as high as 80%, whereas standard chemo was only about 30%. So obviously you can see that that's a drastic improvement. The duration, however, was still short. The remissions were only lasting about 4.6 months. And that was despite the fact that a lot of these patients were being what we call MRD negative, so not having that minimal residual disease in their body. So once again, it might show that a fair number of these patients need to go on to a stem cell transplant as their next therapy, and 44% of the patients did, which was more than the 18% of patients who got just chemotherapy, because more of the patients got into remission, so they were eligible for transplant. So that's very important for being eligible for transplant. The reason that most of the patients came off of the Inotuzumab study was because they had achieved a complete remission and they wanted to do something like a transplant. Whereas with chemotherapy, many patients did not respond and had resistant disease. And then finally, I'll introduce the idea of a chimeric antigen receptor T cell. And I think this has been talked about a little bit in the news. We call it a CAR T cell for short. And the general concept is that you're collecting your own T cells. So a little bit like when you have an autologous transplant done, they will collect your cells before the transplant. And then they will engineer the cells and get it to express an antibody receptor, similar to the other antibodies that I showed you, that will recognize the leukemia cell. And so then we infuse it back into the patient after it's grown some in the lab. And in the patient, it gets activated by recognizing the leukemia cell and then ultimately kills the leukemia cell. So here's another picture of our Y-shaped antibody idea that we've talked about earlier. So this portion, similar to Blinatumomab, is against something called CD19 on the leukemia cell. It also has a part that targets CD3 that we also saw in Blinatumomab, which activates the T cell. And then they add in a little extra part to extrally boost up the activity of the T cells, the CD28. And they actually use a virus to essentially insert this modified antibody receptor into a normal T cell, and then they grow it in the lab, and they send it back to us, and we infuse it into the patient, a little bit like getting just a normal transfusion. It takes about 30 minutes to infuse. And then they recognize the CD19 on the leukemia cell and become activated and kill the leukemia cells. So this is some pretty serious treatment in terms of what patients have to go through, and I'm sure Dr. Stiff will talk a little bit more about this. Some of the common side effects are cytokine release syndrome, which I talked about a little bit with the Blinatumomab, and this idea of causing fevers because you're activating the immune system and having a general inflammatory or immune response. Sometimes, though, patients can get pretty sick, and they can also have low blood pressure, and they might need a lot of support for that. And their oxygen level can also drop, and they might even need to be on a ventilator to support them for that. Patients can also have neurologic symptoms. So like Blinatumomab, it could be mild, like delirium or confusion. But some patients had aphasia or stroke-like symptoms where they can't talk, and others did have seizures. And a lot of this also seems to correlate with when there's a lot more leukemia present in the body, but we don't exactly understand why the neurologic symptoms happen. It usually happens in the first 14 days after the T-cell infusion, so we do require that patients be in the hospital. And usually, cumulatively, patients might be in the hospital 4 to 8 weeks with getting this treatment. So I just wanted to summarize some of the different clinical trials that have been done, and I know that this is a busy slide, but if we could highlight that essentially the response rates are quite high, between 70 and 90%. And many of these patients were very sick and had a lot of leukemia. And in terms of becoming negative for this minimal residual disease, that was about 60 to 80% as well. There were high rates of this cytokine release syndrome, Anywhere from about 75 to 90% of patients experienced it, and about 50% of patients did have those neurologic side effects. So that's all pretty serious. Now, these are really new treatments, so the follow-up of these patients hasn't been very long. So they've only been followed for about 6 to 10 months in a lot of the trials that have been reported. And the survival data that's been reported is pretty mixed. So we need to learn a lot more about these treatments. And I think some of the questions that come up are, how long does a CAR T cell last in my body? And if it's going to last for a really long time, do you need an allogeneic transplant after achieving a remission with a CAR T cell? And we don't 100% know the correct answer to that. And maybe Dr. Stiff will have more enlightenment on that than I do. There was one trial that did show that if you could become negative for that minimal residual disease with CAR T cells, that you did just as well whether you had a transplant or you didn't. So this is really what some of the current CAR T cell trials are trying to answer. And the other thing is, if the CAR T cells sort of wear out and disappear from your body, could you just get retreated with it? And that's kind of the next question that a lot of the clinical trials are trying to answer for us. So I think it's an exciting new treatment. It is fairly toxic and hard for some people to tolerate in terms of the side effects, but it does seem like it's very effective and has a potential to be something that could be an exciting new treatment. And maybe for some patients who aren't a good candidate for a transplant or very rarely do not have a donor option for a transplant, this might be somewhat of another treatment they could consider. So I touched briefly on the more common side effects. Some of the other things, and maybe Dr. Stiff will talk about this as well, that we just don't know about is, could I react to having the T cell infused? They haven't seen this yet in the clinical trials. Could you have tumor lysis, which is really rapid breakdown of the leukemia or lymphoma cells? And that can release a lot of chemicals into the body, which can be a big burden, sometimes especially on the kidneys. When we're inhibiting your leukemia cells, some of those markers on the leukemia cells are also on normal immune cells called B cells in our body. And so sometimes those can also be decreased by these treatments. And so the question is, would you be at a higher infection risk? And they haven't seen that yet in the trials. Could you develop graft versus host disease for patients who have already had a transplant and then they have CAR T cell treatment done? The CAR T cells that are developed for them might have actually derived from some of the donor cells they still have in their body. And so you don't know if maybe graft versus host disease could be worse for them. They did use a virus to engineer the T cells, and so we haven't seen any cases of it, but could the virus become active in the patient's body? Will the T cells for some reason just turn on and kind of proliferate a little bit like a cancer cell will? We haven't seen that in any of the trials, but we need to learn more about it. And then ultimately, this is a genetically modified product that we're putting into our bodies, and could it somehow actually insert into the DNA and cause, in the long term, more damage and other cancers? And these are pretty new therapies, so we haven't followed patients that long. So we don't know the answers to those things. But these are all things that we as your doctors are thinking about and that are certainly coming up in clinical trials. So to summarize, I used acute lymphoblastic leukemia as a model for immunotherapies. Many of those treatments I talked about in different ways or in slight different variations are being investigated in other leukemias or in other lymphomas. And I think it shows that we can certainly copy the immune system with an antibody, or we can utilize it in order to attack our cancers. And there are so many new immunotherapies just for acute lymphoblastic leukemia alone. So in this case, I think it raises the question that we need to be comparing all of these different treatments so we can know which one might be the best one for you. But until those clinical trials are done, what do we do as physicians? We try to look at a lot of the side effects, as Dr. Patel touched on earlier with multiple myeloma. We have all these new drugs. And so certainly things like costs are a consideration, but I think side effects are also a big consideration for patients. And we want to think about how toxic is a drug for a certain patient And would that be the right side effect profile for that patient? Would they be able to feel good while they're getting the treatment and come out the other side and have a good quality of life? As Dr. Burns had touched on earlier, we want you guys to feel well as you survive these leukemias and lymphomas. And then finally, I think that so many of these treatments are new, and as I touched on, we don't always know exactly how to order using them or how to combine them with other treatments. And so your doctor's probably going to be talking to you about a clinical trial with some of these new drugs and how you can best utilize them. Okay? I was tasked